Thank you very much for that introduction, and thank you to the organisers. It's a real pleasure to be here. I'd like to also acknowledge the traditional owners of the land on which we meet and pay my respects to elders past and present. And I'd like to start with a story. So a few years ago, my then 7-year-old daughter told me with the utmost earnestness, "Mum, I never want you to die." And she then followed that up with a question. So looking at me expectantly, she asked, "So what's the best thing you can do to stay alive?" Now, naturally, as a scientist, I began thinking about my answer in light of various forms of evidence and data. And I started thinking, what does the evidence tell me is the best way to stay healthy and to stay alive? And one of the first forms of evidence that came to mind was this burden of disease data, which tells us about how much disease in the world is attributable to different types of risk factors. So I considered if I weighed up data like that, then historically, given the position of tobacco smoke exposure as a leading risk factor for many chronic diseases, then that was probably, not smoking was probably one of the best things I could do to stay alive. But then weighing up sort of more recent data, and particularly data from countries like Australia, where I know that physical activity is particularly important, as are various dietary components, I started thinking that maybe these kinds of behaviours were a better bet and the best thing that I could do to stay healthy and to stay alive. Then I started thinking about how in our ageing population, mental health impairments like depression and dementia are increasing burdens, and I wondered whether in fact brain exercise and keeping free from stress was the best thing to do for a long, healthy life. So I pondered on all of this and on which of these I could tell my daughter is the most important determinant of staying alive and staying well. Now, in fact, the answer to that question is not on this slide at all. In fact, the most important thing that we can do to prolong our life and preserve our quality of life is this: where we sit on the social scale. So the lower our social position within our society, the worse our health and the more likely we are to die prematurely. And there's extensive evidence showing that in general, people who are at the bottom of the social scale, the most socioeconomically disadvantaged, are worse off than those less deprived. But also the slightly less deprived are worse off than those with average levels of deprivation and so on. So that slope linking deprivation and health, it's called the social gradient, and we see this everywhere in all countries. And it's of such concern that the report of the Commission on the Social Determinants of Health that was established by the World Health Organization in 2005 to help address health inequities concluded that social injustice is killing on a grand scale. So with that in mind, take a look at these numbers. On the 10, there's not, that should be number 10, 1 and a 0. It's come out a little bit skewy. Have a think about what these might represent. Now, this is a tough question without much context, so here's a couple of clues. So these numbers represent the years of difference in life expectancy according to 4 characteristics. So firstly, a child born in an affluent neighbourhood of Glasgow in Scotland can expect to live a life up to 15 years longer than a child born only 7 kilometres away. Now, you might say, but Australia's more egalitarian than that, that wouldn't happen here. Well, unfortunately, we see inequities much closer to home. Indigenous Australians can expect to live 10 years less than non-Indigenous Australians. And we need to be careful not to use Aboriginal status or race or ethnicity as interchangeable with socioeconomic disadvantage, but the reality is that some groups, such as Indigenous people in Australia, are much more likely to be amongst those who are most disadvantaged in our society. In Australia, there's roughly a 6-year difference in life expectancy between those in the highest income and the lowest income quintile. And there's a 5-year gap for those with high versus low education level. Are you shocked by these? I think these are shocking differences in life expectancy, but there's more. People experiencing socioeconomic disadvantage don't only die sooner, but they'll also spend more of their shorter lives with a disability or an illness. So upon reflection, I realised that the best thing I could possibly do to try and stay healthy and alive was to be positioned as high as possible up that socioeconomic ladder. Now, so that we're all on the same page in terms of what we mean by socioeconomic status or socioeconomic position, a pretty widely accepted definition is that a socioeconomic position refers to a person's economic and social position in society relative to others, and this reflects their access to material and social resources. So when I'm talking about socioeconomic disadvantage, I'm not only talking about poverty or extreme disadvantage, but rather a social gradient whereby the lower the position, the worse a person's health. And some of the most commonly used markers of socioeconomic position are shown here, and it's important to note that while these are not interchangeable and they reflect different aspects of socioeconomic position, the findings I'm talking about today are generally robust no matter which of these indicators is used. Now, as we just heard, there are also inequities in physical activity participation and in health according to other social stratifying variables, so things like gender, race or ethnicity, disability. But in the interest of time and the focus today, I'm focusing here on socioeconomic disadvantage, so on the indicators shown on that slide here. So I'm going to talk now about one of the key behavioural factors that contributes to life expectancy and to quality of life, and that is physical activity. So I'll briefly present the evidence that there are inequities in physical activity participation according to socioeconomic position, but then I'm going to focus most of the remainder of the presentation on what we might do about these, so on some successful models that have been put into place. But first of all, let's look at the evidence for some of those inequalities. So in developed or high-income countries like Australia, there's lots of consistent evidence that socioeconomic position is positively associated with leisure time physical activity in adults, including in older adults. And now I'm talking particularly about leisure time physical activity because that is often the most discretionary form of physical activity. The patterns are a little bit more mixed if we consider things like occupational activity or transport-related physical activity. But in today's increasingly automated society, it's generally not the case that people are making up for low leisure time physical activity in very active jobs, for instance. So this is again a graded relationship, and this is just one example from one of our studies, but there are many, many examples I could have shown here. And this one shows that the odds or the likelihood of doing any walking in your leisure time are graded according to education level. So people with less than 12 years of education, the least likely to be doing any walking. Those with middle levels, a little bit more likely, and those with university education, the most likely to be engaging in walking in leisure time. So what about sedentary behaviour? We know that sitting too long is an independent risk factor for chronic disease, and the evidence also shows us that there's a socioeconomic gradient in the time we spend sitting and in major sedentary behaviours like watching television. So, for example, people with the highest education levels spend the least amount of time watching television in their leisure. And interestingly, some recent evidence shows that this gradient might be more pronounced after retirement. So this figure here, while there's not much going on with the blue bars, which represent people who are still working, the red bars there, those who have retired, show that there's a clear graded relationship between lifetime occupational class and the proportion of waking time spent watching television, with the least skilled occupations watching the most television there. So possibly prior to retirement, the constraints of the workplace might be masking some of these effects that may be more apparent at weekends, but it does suggest that there is this graded relationship, particularly that's pronounced after retirement in older adults. So there's lots and lots of evidence that supports what I've just shown, that there are socioeconomic inequalities in physical activity and in sedentary behaviours. But what causes these? Well, this is one potential explanatory model that's been put forward by Vic Health, and this is the FAIR Foundation's framework. So this framework outlines the social determinants of health inequities, and it suggests some potential entry points for action. So this and similar models like this, like social ecological models, for example, suggest the importance of focusing at multiple levels. And in this particular framework, those levels are firstly at the broad socio-economic, political and cultural level at the base of the framework there. Then at the level of daily living conditions, including the settings where we live and work and play. And finally, at the level of the individual. So it's important to note that health inequalities result from social inequalities. So social determinants like employment conditions, living standards, income, housing, and they're not explained by behaviours alone, so by physical activity alone. So addressing health inequalities requires action on the social determinants, for instance, via progressive social and economic policies that address some of these social issues. A focus on behaviour doesn't and shouldn't replace that, but it's important not to forget that it is a part of the solution. So we know physical activity is a key health protective factor, and inequalities in physical activity play a role in contributing to inequalities in health. So for the remainder of this presentation, I'm going to present a bit of a snapshot of current evidence and what we know from the evidence about approaches to promoting physical activity equitably that have worked at each of those levels of the framework. And these approaches are summed up in a couple of different papers if people are keen to read more about these. So these two papers, published in Health Promotion International and the second one there in the International Journal of Behavioural Nutrition and Physical Activity, are both open access papers, so anyone can access those. And if you can't find them and would like to read more, please drop me an email and I can send those to you. Some of these approaches are also summed up in this document, The Blueprint for an Active Australia, that was led by the Heart Foundation, and this is a call to action for a 13-point plan to get Australians moving. Again, you can download this directly from the web, from the Heart Foundation's website. And this is one of the key action areas that I led about disadvantaged populations and addressing inequality. And somewhat disappointingly, this chapter is one of the least downloaded chapters of that entire blueprint document. And often this is the case when we talk about disadvantage. I think people assume that this is just too hard or that it's someone else's problem. And I think this is wrong. I think that addressing inequities is something that we should all be striving towards, and it's actually for everyone's benefit. So action taken to reduce inequities don't just benefit the most disadvantaged, it benefits society in a whole range of ways. So apart from enormously important issues of social justice and human rights, it also has significant economic benefits associated, for example, with losses resulting from inactivity to productivity, increased tax revenue and so forth. So there are lots of reasons that all of us should be striving to address inequities in physical activity participation. So here are 9 promising approaches to addressing physical activity equitably, and I've mapped these against the levels of the FAIR Foundation's framework and summarised them here. And I'm going to start with the broadest level at the bottom here. So at that level of socioeconomic and political context, some of the approaches that have shown promise for promoting activity equitably include governance and partnership approaches, policies focused on transport or neighbourhood design, and social and cultural norms. And I'm only going to allude to this level briefly because I've been told that it's probably outside of the remit of most of us in the room today, but I will touch on some of those potential approaches. Then there are approaches at the level of daily living conditions and the settings in which we live, including health and employment settings, and approaches involving social support. And then finally we have at the interpersonal level selected individual tailored approaches. So firstly, let's look at promising approaches at that very upstream level of governance and policy. So examples at this level that have been trialled before include governance and partnership approaches where, for example, local and state government and community organisations are provided with support and incentives to work cross-sectorally together to develop and implement policies and practices to promote physical activity across the life course. And one very early example of this was the whole of government approach that New South Wales took back in the early 2000s, during which the Premier established a New South Wales Physical Activity Task Force, and they developed a comprehensive strategic plan for physical activity promotion in New South Wales. So every government department was instructed to focus on physical activity promotion. And the available evidence suggests that this example and approaches like this generally show a lot of promise in harnessing that broad cross-sectoral buy-in and also engaging communities and individuals across the entire socioeconomic spectrum. Now, another example at that societal or policy level is transport policy and practice, and this can include improving transport infrastructure, safety, or providing incentives that encourage walking and cycling as active modes of transport. And one really successful example comes from Colombia, So this is Bogota, which is home to the world's largest ciclovia. So this is a free community-based program where the streets of the city are actually closed down temporarily for a day a week or a morning a week to motorised transport, and they're given exclusive access to walkers, runners, cyclists, rollerbladers and so forth. And this is an amazing model. It's actually inspired similar models in more than 1,500 cities around the world. And it's been shown to be cost-effective, but also effective in engaging people. So people who participate or even who live near these ciclovias tend to be more physically active than those who don't. It also attracts a good spread of people from all different backgrounds, including socioeconomically disadvantaged groups. So another example at that broad level of a very successful approach. So the third promising approach at that broad level involves campaigns to try and change social and cultural norms around what's perceived as normal in terms of physical activity for older adults. Now, unfortunately, there's not a lot of evidence for effective approaches to doing this at a whole population level. It's a very challenging thing to shift social norms across an entire population. But this recent smaller scale study caught my attention as a novel way of changing social norms in a more contained setting that could be relevant here. So in this particular study, older results in a residential care setting weren't aware of the purpose of the study until afterwards, but they were provided with one of two different news reports and asked to comment on it and give their opinion about which photos they thought should be used in these reports. So one version of the report was titled "Increasing Numbers of Exercising Older Adults in the Local Community," and they had a couple of photos that showed older adults engaging in physical activities that could be included in that news report. Not quite as extreme as this remarkable lady here, but certainly some walking and local level physical activities. So this version conveyed the active social norm of other older adults, peers, being physically active. So the other group in that study just got a different version. They just saw a news report titled "Older Adults in the Local Community" and some photographs of non-active older adults. And the researchers found that this unaware exposure was enough to promote intention to participate in physical activities offered by the residential setting, and also it predicted participation in these activities up to several months after the study. So this is really small and it's in one setting, and it's not known how well this might translate on a broader scale, but I thought this was quite a neat example of a fairly simple thing that can be done to potentially shift social norms around activity in older adults. So moving up now to the next layer of the framework, and I'll talk a little bit about approaches at daily living conditions, and the first of these are community-wide approaches. So these tend to be very large, highly visible, multi-component campaigns, like the 10,000 Steps campaign, if anyone remembers that was in Rockhampton. They involve multiple sectors, partnerships and components like these: community events, mass media, support groups, risk factor screening, education at work sites. So they're quite large initiatives. But reviews show that these can be effective and that they are promising, as they can potentially reach a broad spectrum of people across entire communities. Although, admittedly, the evidence for engaging the most disadvantaged people in those communities with this kind of approach is still somewhat lacking. So we need to know more about how effective these are in disadvantaged groups. So settings-based approaches. So there are a number of settings in which older people spend their time. Here's one key setting that's shown promise for equitable physical activity promotion, and that's the local neighbourhood. And initiatives in this setting include those that target the physical environment, so things like public open space and green space. So ideally, initiatives like this are supported by informational outreach. So simply making some changes in the environment often isn't enough to engage people. But for example, via local media and other avenues for promoting environmental facilities so that residents are aware of these. And one successful example of this that I was involved in, led by my colleague, Dr. Jenny Veach, was a park refurbishment project in Rosebud, which is a relatively disadvantaged community in Victoria. So this park was enhanced down there from what was a pretty bleak area in the top left photograph there to quite a pleasant area with some walking trails installed, a picnic area, barbecue facilities, a dog walking area, leash-free zone. And we evaluated park use and physical activity in that park and compared it to a matched control park. And what we found was that park use, walking in the park, vigorous activity in the park, all increased quite dramatically following the enhancement compared with a matched control park. So another promising way of engaging people in their local neighbourhoods and promoting physical activity in those settings. So what about workplace settings for promoting physical activity? Now, the evidence for these is a little bit mixed, but they can be modestly effective, particularly if workplace approaches target physical activity only, as opposed to trying to cover off a whole range of different health behaviours. And also if they include motivational enhancements. So that might include things like motivational counselling or interviewing, or they could be things like group-based or individual motivational incentives to be active, like competitions, for instance. And these workplaces can be effective as a setting for physical activity promotion for a range of occupations, including manual occupations and blue-collar occupations, although admittedly the bulk of the evidence has come from non-manual or white-collar office-type workplaces. And one of the challenges with these, obviously, is to extend the success of these kinds of approaches to retirees and thinking about other settings once people leave the workplace, the workforce. So one of those other settings are healthcare services, and these have also been targeted in physical activity promotion trials. Now, to date, most of the work in these areas has been done in primary care settings, and these include things like the green prescription. Are people aware of this approach, green prescription? No. So basically a GP usually, or another healthcare provider, provides a prescription to exercise, so that their written advice basically, do 30 minutes of walking 5 days a week. And reviews have showed that these kinds of initiatives can be effective, although the impact is relatively modest, and it needs to be more intensive than just a one-off advice. So simply handing somebody a prescription like that is not going to be enough to affect physical activity behaviour change. But it is a potential setting in which we can reach and possibly impact behaviour for a broad range of older adults. There's unfortunately limited evidence on how linkages and partnerships between different health services might benefit this approach. And to me, I think that's a real missed opportunity and something we should be thinking about, given the evidence that more intensive interventions that are supported by messaging across a range of different providers are likely to be more effective. Unfortunately, there's also relatively limited evidence about the equity of these kinds of effects. So it's not that they don't work for disadvantaged groups, it's just that we don't yet have the evidence about their impact. Now, this type of approach, social support and group-based approaches, I think hold incredible promise for equitable physical activity promotion. Social support for physical activity can be provided in a whole range of ways. That don't need to cost a lot, that are implementable in diverse settings. They can include things like establishing buddy systems, having people make contracts with others to be active, sign a behavioural contract to be active. It can involve peer or professional coaching and support, or it can involve walking or other activity groups that can provide support and companionship. And a number of reviews that have focused specifically on socioeconomically disadvantaged participants have now concluded that this element is critical. So in fact, this review, led by my colleague Verity Cleland, found that social support was the main element that distinguished successful programs, physical activity programs, for disadvantaged women. So I'm going to talk now about one local successful example that's used this kind of approach, and that's Heart Foundation Walking. So many of you are perhaps familiar with this approach. So this is the largest walking group program in Australia. It's community-based and it's free, so there's no economic barrier to participation. And it involves the Heart Foundation partnering with local coordinators to establish walking groups that are led by volunteers. And the volunteers are people who live in the communities and who lead those walking groups. The approach is very flexible, so the groups can be any size. The largest groups have more than 300 people walking in them. Any time of day, the walk lengths differ and they cater to different levels of difficulty. Everyone's encouraged to walk at their own pace. There's also a virtual walking community for people who like to access the support of others but maybe can't or don't like to or can't access the actual physical walking groups due to geographic or to other barriers. And there are also a number of other specialty groups, so groups for those over 50, groups for those with special needs like diabetes or disability, Aboriginal and Torres Strait Islander groups, groups for culturally and linguistically diverse people and so forth. So I recently assisted the Heart Foundation to evaluate this program, and here are some of the evaluation data. Currently, there are more than 24,000 people registered in walking groups, more than 1,100 groups across Australia. And over the last 20 years, walkers have clocked up more than 5 million walks, so it's quite a phenomenal effort. The average group walks for 49 minutes once a week. Retention rates are very good. And yes, as I said, some groups have been walking for more than 20 years. The average group's active for about 3.6 years. But what's even more positive, I think, is the good reach to low socioeconomic groups. So, for example, 42% of participants have a gross household income of less than $40,000 per annum. So it's quite a low income threshold. So it caters well to these groups. So why do you think it might be that people come to these groups and then stick with them? Social, yeah. So no cost, absolutely. The lack of economic barrier is critical. And then the social factors. So the walkers have been asked why they come and why they stay. Many of them come either because they've been told by their doctor they need to come, or they've had a heart attack or another incident and they need to do more activity. But the reasons they stay are not the health reasons primarily. They're rated third. It's the social aspect. So once again, a clear message that for socioeconomically disadvantaged populations, social aspects seem to be critically important. And finally, individually tailored approaches. So these can include approaches that target intentions to be active, and one of the simplest of these that's been trialled many times and shown lots of success is a really low-cost point-of-decision prompt, like a sign posted alongside a lift or an escalator encouraging stair use. And there's a lot of different ways that can be done. Here's just one example there. These have been shown to be effective across a whole range of target groups, including disadvantaged groups in different settings, and the effects can last up to several months even after the sign's been removed. So another individually tailored approach involves motivational approaches, so approaches that target people's motivation to be active, and this can be done through things like motivational interviewing or counselling, but it can also be done through simple things like a pedometer or a Fitbit. And many of the participants in our studies tell us that even though we offer them a whole range of things in some of our studies, the Fitbit or the pedometer is often their favourite aspect of the intervention. They like the self-monitoring and the challenge of trying to beat their step count or their activity count each day. So the last two examples are also individually based approaches. So these include cognitive behavioural approaches and mediated approaches, so those delivered via different channels or platforms. So cognitive behavioural approaches are those that use a range of both cognitive techniques like counselling, but also behaviour change techniques, so things like goal setting, self-monitoring, addressing barriers, preventing relapse and so forth. And these are more effective than just health education alone or physical activity instruction alone. Again, have been shown to be effective with a range of different target groups, including disadvantaged groups. Now, individual approaches like these are often delivered face-to-face, but there is some evidence they can also be done effectively through other mediated approaches, so things like telephone-based approaches, print-based approaches, or web-based. So our study there was one of the very early studies, the first study in Australia, in fact, that trialled a print and a telephone-based approach for promoting physical activity in middle-aged and older adults. And what we found was that a tailored program that included regular phone calls to the older adults and behaviour change strategies such as setting some physical activity goals and providing feedback on their progress was effective in increasing physical activity among that target group. Digital delivery of approaches, so things through telephone apps or web-based, is an emerging and a promising area, particularly given the high saturation of these technologies across Australia. But we still don't know a great deal from the evidence about how effective they are, or particularly how equitable they are as promotion approaches. But this is another promising area of investigation. And it seems in all of these approaches that several components seem to be particularly important in successfully increasing activity. So these include individual tailoring to individuals' preference and needs, theoretical frameworks and behaviour change techniques that I've spoken about, focusing on physical activity alone as opposed to other behaviours, and on physical activity that's simple, that's convenient, that's moderate intensity, and also that's low cost. Ideally, these individual approaches would also be supported with strategies to help support that behaviour change through environments that support that, so helping individuals become aware of the facilities and supports for physical activity in their local environment too. So that's a quick wrap-up, very quick wrap-up of 9 potentially promising approaches. They are described in more detail in the papers that I referred to, so let me know if you can't get a hold of those. So I guess just a quick sum up is that we've seen some promising approaches across all of these levels of the FAIR Foundation's framework, the policy, societal level, community and settings and individual levels. I am particularly excited about the latter group there, those that are group-based, those that are tailored, cognitive behavioural strategies, and those that combine that individual tailoring with supportive environments for physical activity. So just some final words. Social injustice is killing, and this is shocking. Reducing health inequities is a matter of fairness and social justice, and we should all be designing our physical activity programs or policies to impact and reach those with greatest need. So this is a call to action to all of you today in any program or policy that you're involved with, to make sure you ask not only does it work to improve physical activity, but also does it work to reduce inequalities in physical activity behaviours. I think it's our duty to all be striving for a society in which the 7-year-old sons and daughters, grandsons and granddaughters of the poorest families have just as much chance of seeing their parents and their grandparents live active and long lives as those from the wealthiest families. And the good society is one that does this, that works to bring well-being to all of its members. Thank you.
Well, that was fabulous. Thank you, Kylie. And now is your opportunity to ask some of those questions that I saw you all writing down. So this is it. You're going to be the first person to ask a question. Please don't make me like an auctioneer that has to put in a vendor bid to start. Do we have any questions? We've got about 5 minutes for questions. You're going to make me do it, aren't you? Well, I will. There is one. Thank you.
Thank you, Kylie. That was fantastic. Melanie Smith, Active Ageing Australia. So I'm wondering, looking at that evidence, have you got any examples around the world that use every level of the ecological approach and have shown success?
Yeah, that's a great question. Thank you, Melanie. I think off the top of my head, probably the closest examples that do that are those whole of community approaches. They tend to be quite expensive approaches. That's the upfront. That's the difficulty, I guess. But they do involve both broad sort of policy and environmental change, often new infrastructure, alerting people to infrastructure for physical activity, but they're also based at that settings level, so they're in communities where people are living, and they involve that kind of cross-sectoral promotion of activity, often at very local and individual levels. So, and the evidence does suggest they can be effective programs. So I think I mentioned 10,000 Steps as one example of that one. There's another example in the US called Wheeling Walks, which if you look up, there's quite a lot of evidence about how they went about that and what they did. I think they take a lot of time and they take a lot of commitment, but the level of intensity and buy-in that results from that, I think, is highly effective and a promising approach for actually having impact that's hopefully sustainable. Thanks.
Aha. So, yes, hand up, and if you could just introduce yourself too, please.
Rebecca Luxford from Rhythm of Life. Kylie, I noticed one of the references of your information was 2005. In those last 12 years, has there been any other research in that to see any time frame, whether there's been greater improvements?
So thanks Rebecca, I think you were referring to the print and telephone based study that was effective in promoting activity in middle-aged and older adults. Yeah, and so look, I did use that one even though it was a little bit dated because it was one that I'd led, so I was familiar with it and knew that it was effective, and as I mentioned, the first in Australia that had trialled those approaches. Look, since then, to be honest, the academic field does move pretty slowly, so there have been a number of review papers since then, and I can perhaps offline provide you with the details of some of those a meta-analysis that Con and colleagues conducted a couple of years ago that are probably good examples in that they sum up a whole range of literature rather than just one or two isolated studies. But look, the snapshot overall that I provided, I think, still probably reflects the best evidence sort of in the field as a whole. If there were particular sort of one-off additional studies that have added to that, they're often captured and represented in that meta-analysis or review approach. Yeah. Thanks.
Ornella Clavisi from Move. I just was interested with the green scripts and whether health practitioners have or require additional training to try and motivate, so like health coaching for their patients, and whether the effectiveness of those sorts of additional training actually makes an impact on people becoming physically active.
Yeah, that's a good question, Ornella. We have done, my colleagues historically have done some work with GPs and also maternal health nurses and some other practitioners around their understanding of, I guess it was more related to obesity in that case, but what they found is that while a lot of practitioners see this as very important, a lot of them don't feel confident in themselves about the kind of advice to give, both in terms of physical activity but also eating. I do think that there's good potential there for some professional training and capacity building around the kinds of messages that might be effective. In terms of whether that's been done and the kind of impact it's had, I don't know, to be honest. In Australia, I don't believe there's been an initiative of that nature around physical activity. Internationally, I haven't come across the literature. That's not to say that it's not there, but I do think that's a very good potential area that we might be thinking about and building more evidence in because of the potential to reach such a broad spectrum of people, particularly in this target group. Yeah.
And last question, just...
Oh, yes.
Just to comment on that, if I may, there has been some work done to look at health professionals giving advice, and there's certainly evidence particularly from New Zealand, that it does work. The sticking point has always been that unless there is a particular incentive for people to provide that in a way, for example, like with an MBS item, the practitioners just don't want to know. I mean, across the board, there are clearly keen people who will do it, but yeah.
And because that was short and sharp, I can squeeze another one in just down here.
I don't totally agree with because I do health coaching. Mm-hmm. So I think most health coaches, whether they're doctors or exercise physiologists or physiotherapists or nurses or allied health practitioners, I think have some kind of training where they can, But I think the whole thing is about integrated program that really needs to be looked at in the whole of Australia. So it's just not social injustice, but justice about how we can do it so that it becomes, has an impact on people to really forming that good society. Mm-hmm. Like it's a one program, and how is it going to work?
Oh, absolutely. I'm in vehement agreement with you. And I think, you know, we know that any one program on its own is probably not going to work. So how is it that we can get that buy-in and coordinate that across different sectors? I agree, it's a critical point.
Well, thank you very much, Kylie. And I'm sure you'll put your hands together for a fabulous